All right, so I want to welcome and introduce you all to our two speakers today. We're very excited to have both. First, I'd like to introduce Dr. Kurt Devine. He began his family medicine career in a rural community in central Minnesota in 1990. After 25 years of full spectrum family medicine, his career path was forever changed in 2015 after he and a colleague developed a rural clinic and community model to address opioid prescribing and lack of access to medication-assisted treatment for opioid use disorder. MDH funding has allowed this model to be implemented in 12 other rural Minnesota communities. And then in 2018, a weekly opioid addiction telehealth teaching program through Project ECHO started bringing weekly addiction information to rural community providers in an effort to improve care to patients with substance use disorders. Similar projects were also launched to target medical and the PA students that were in programs that emphasized care to rural and underserved communities and were facilitated by Dr. Devine and a colleague. Grant funding for these programs and now new projects are currently managed through Stratus Health, for whom Dr. Devine works. He's a subject matter expert there on grants related to rural addiction care, opioid prescribing, and addictional care in correction facilities. He has also been involved at the state level regarding opioid issues, serving as on the opioid prescribing work group to develop state guidelines, and currently sits on a DHS pain waiver advisory panel and the MDH task force for pregnancy and substance use disorders. Dr. Devine achieved board certification in addiction medicine in 2020, and in 2022, he joined Centra Care Organization and became one of two providers in their addiction services clinic. Our other speaker today is Erin Foss, RN, CARN. Erin serves as the program manager and subject matter expert in opioid stewardship and addiction medicine at Stratus Health. She's worked in the healthcare industry since the age of 16, starting as a nursing assistant with a continued passion for learning and advancement. Her curiosity and constant yearning to learn brought her to addiction medicine, where she was a shareholder in the programmatic development of a nationally recognized addiction medicine program. She has also been a featured key speaker at several international and educational events that encompass addiction medicine. Erin realized in caring for addiction patients and disseminating the knowledge to reduce stigma that she is passionate about enhancing the lives of the underserved patient population. She acted as assistant director of nursing for a large correctional care organization, providing leadership and on-site oversight to 49 county jails across the upper Midwest. Erin joined Stratus Health Team in 2021, and she has provided education, support, mentorship to 13 rural community healthcare organizations and 4 county jails across the state of Minnesota to employ medication for opioid use programs within the facilities. She now provides mentorship at the national level, serving the Bureau of Justice Assistance and county jails across the United States to integrate addiction services within their facilities. She has served as a clinical consultant to the Department of Human Services in the opioid initiatives that include the Prescribing Improvement Program. In addition, she's a co-facilitator of one of the largest addiction medicine echoes in North America, with determination to reduce opioid-related morbidity and mortality through stigma reduction and educational efforts. So very clearly, we have two very well-versed and knowledge folks to speak with us today. So at that, I'm going to turn it over to Erin and Dr. Devine.
Yeah, I think first off, that made us sound a lot busier than I think we really are. And one thing I like to say is that Erin and I have been working together probably for about 6 or 7 years, because a lot of these programs, excuse me, that we did were, she was part of that program that we ran through the community that we were living in at the time. So we've known each other a long time, but we have never given a talk together. We co-facilitate the ECHO. But we'll see how this goes. It could be a real fight to see who gets to talk the most. So we'll see how this goes. So she's going to pull up the slides, and we'll kind of get going. Kind of a long title to this. I think I'd have probably just said, let's just talk about opioids, and it would have been a lot shorter. But we're we're going with how to implement proven opioid stewardship strategies while integrating quality measures for improved population health. So happy to be here, and
Thanks for having us.
thanks for having us.
Is it following us okay? Our slides are advancing. Perfect. We have no financial disclosures. I don't know if you've recently come up with any, but I
No,
sure haven't.
hasn't been raining money on me, so
All right, our objectives for today are going to be, upon conclusion of this webinar, we hope that all participants will effectively be able to perform patient safety, stigma, and harm reduction interventions, apply non-punitive approaches and carefully curated scripting in dealing with opioid use disorder, opioid controlled substance patients, or addiction medicine patients. Demonstrate and evaluate multimodal opioid stewardship strategies, and effectively utilize data to support patient safety, quality, and overall population health.
yeah, I'm not sure you're going to remember all those things, kind of hoping not, because maybe we won't hit them all, but we'll try. So this is a picture of the Viking Stadium, and I think some of you may have been there, maybe not.
We have a lot of Texans in the group today, it
Yeah.
looks like.
But yeah, this really represents the number of people that are dying each year from opioid overdoses. And I don't think we think about that often, but when you look at that number, it's pretty stunning.
Yep, this is just a very visual representation. And overdoses from opioids have surpassed motor vehicle casualties, just to kind of put in perspective what an epidemic we're really coming into.
Now, I think one of the things to understand, and when we talk to people, and the different things we do, there's always going to be opioids. And there's always going to be patients that need opioids. And I think that that's got to be the first thing that we all agree on. I don't think they're going to just go away. You know, we ran this Tackling Overdose with Networks, which was our community program. And basically, we were trying to promote an approach that really included kind of multiple strategies to kind of reduce opioid overdose and actually reduce how many people were being prescribed opioids.
So the purpose of this program was really to disseminate knowledge and encourage safe monitoring and prescribing, and being able to identify folks right in your clinic that you're already seeing that potentially needs some additional services and help.
Yeah, and really, again, the biggest word there, safety. So we were trying to decrease opioid overdose and really screen for patients at high risk. And we're going to talk about some of those things that would put people at high risk.
So how did we begin? We started by developing a patient-centered care coordination team, and we didn't really know what to call it, so we just called it the Controlled Substance Care Team.
It was a made-up name at a very short meeting. So, so one of the things that really, I think, before we get started on a lot of stuff, is just to understand that we're talking about opioids. We want to talk about safe levels of opioids, and many of you are familiar with the CDC guidelines. Minnesota has their own guidelines. 100 morphine equivalents, or if we talk about morphine equivalents, everything is kind of compared to morphine. And so if I've got 10 milligrams of morphine, for instance, that's 10 morphine equivalents. In oxycodone, if we had 10 milligrams, it would be 15. So a lot of this is based on, it's standardized by morphine, but understand that a lot of the drugs have different strengths. And it's important to understand that when it hits 100, that's typically where we see the most adverse events. And so as we go forward, understand that that's why a lot of the guidelines were set the way they were. And just to understand as well, there's no safe dose of opioids. Even when we look at these low doses, where people are on very small doses, we can still see all kinds of problems. So it's not specifically how high it is. People make mistakes, overtake it, and take other drugs with opioids that cause problems.
So controlled substance care planning. So we had to kind of figure out a way to standardize the program, not to single anybody out or anything like that, but just to standardize folks that were taking a controlled substance and make sure that they were safely being prescribed their medications. So I'm sure you've heard other terms surrounding a controlled substance care plan, maybe like a pain contract or a pain agreement or a narcotic contract. And do you think this sounds stigmatizing? I mean, do you look at it as we don't often care plan patients that have diabetes or patients that have cancer? So why really would we care plan someone with an opioid use disorder or that's needing a controlled substance or opioid substance to manage their pain? So it's just something to kind of consider and think about. So just think about the stigma that surrounds that right off the bat.
And again, the care plans, I think if Aaron and I look back at the care plan that we had 7 or 8 or 9 years ago, I think there was some punitive language in it. And we did a lot of wordsmithing on that over the years to make it much more patient-centered and much more safety focused. And if you look at how now we're even, I think, discussing at many levels whether or not we need care plans and whether or not they should have anything in them that at all isn't shared decision making, right? So it needs to be something that you can have a conversation with a patient about, but not have punitive side effects. And it has to be easy to read.
Yep, I agree. For me, I sort of liken the care plan as an opportunity to have a very frank, open conversation with your patient. So you can talk about maybe risks, benefits, things that go along with taking a controlled substance or an opioid. Care plans shouldn't be a way to fire or cut off patients. I think, nationally, we have definitely recognized that opioids are the cause of a lot of unsafe scenarios and related to a lot of overdose deaths. But, cutting patients off of their medication is not the best option and should never be an intervention that's used to stop opioid prescribing. Also, care plans should never be filled with stigmatizing language. As I said before, this is just a tool to really have an open, honest conversation with your patient about risks, benefits, managing pain, and making sure that they're getting the best care possible and sharing that decision making with them. And we should never put a bunch of complicated jargon into these care plans. We want to make sure that our patients actually know what the heck we're talking about. So that's pretty important.
Yeah. And I think one of the biggest things is really urine screening and whether or not, that should be a part of it. And I think we could spend an hour arguing about that, whether or not we need to be urine drug screening everybody that has a care plan. There's a lot of great reasons to do it. There's some reasons not to do it. And I think one of the things that it assumes is how to interpret it. And I think that's a whole nother hour talk, but interpreting them sometimes can be difficult, especially because of metabolites. Because it really, when we do these, it is all about patient safety. And we want to make sure that the patient's safely getting medications.
Yep, and the whole intention of this presentation is not to say that opioids should not be prescribed. They are appropriate in a lot of situations and patients need them. And that's part of what goes along with a controlled substance care plan or agreement, however you want to word it, whatever you want to call it. But I really like to share a story about an older adult female that I had as a patient that came in and she was taking oxycodone. And we routinely did urine screenings at least twice a year because that's what a lot of insurance companies recommend for safety measures. And her opioid substance was not present in her urine. So it opened up that conversation to say, how has your pain been? Tell me a little bit about, have you been taking your meds? And come to find out that her caregiver had been setting up her meds and the patient was very unaware that her oxycodone was not set up in her medications. So these care plans and these urine drug screens aren't out to get anybody or catch anybody. They're to make sure that the treatment options that we're providing to patients are actually managing their pain and keeping them safe and getting their medication as they should be. So that's just a scenario and a story that I like to tell because it's not always the way we think that would go.
And I think it's important to remember we're not the police. And so our job really isn't to be the police. So, and there's ways of talking about some of the screening and the things we do with patients. And there's clearly some ways we don't want to talk to them about it. And this is just an example of that. When we talk with a patient, we want to make sure that they understand that this care plan is intended to kind of ensure that they have a chance to talk to us about it. We talk about some shared decision-making, the safety of the medication, the complications of these medications, and really some of the issues that might come up that might be a concern for a physician. And so they don't have to be sign this, and if you break this, we're going to cut you off. It has to be a nice conversation.
Yep. And I think the big thing is just not making patients feel singled out. I always included in my talk with patients when going in with a care plan, all patients in our clinic that are on a controlled substance have a care plan. And this is just to make sure that you're kept safe, that we're managing your pain appropriately, that we've looked at all other interventions that could be effective, and we'll get into more of that later. But like the story that I shared, it's not just about catching someone, it's making sure that they're being taken care of the way that they should be and that they're safe. And a lot of people feel very singled out when you ask for a urine specimen. But once again, I always brought up that example with patients. And, I just make it very normalized. This is kind of what insurance is looking for, just to make sure that we're keeping you safe and we're doing the best that we possibly can for you. And just that medications are being prescribed correctly.
I always tell people, if you were diabetic, I'd be getting a hemoglobin A1C and I'd be getting other blood work. So I think there's lots of ways to look at it.
Yeah.
This is actually the way we set up our program in our clinic years and years ago. Again, we're not there anymore, but we basically set up a little group, a physician, an RN coordinator, administrator, and a mental health provider to kind of help us in a way fashion a program where we could start monitoring some of the patients for the physicians and other providers in our clinic. At one point, we did actually add a social worker, and that was really fabulous, because I think a lot of times the issues that pop up are social issues, and a pharmacy resident, which was very helpful as we began our career interpreting some of the urine drug screens and some of those complicated parts of this management of this particular group.
And the particular clinic that we worked in and started this program in was a patient-centered medical home, which was really nice because nursing care coordinators could bill for services when they were doing check-in calls with patients that were receiving controlled substances. So it's nice to be able to have that added care coordination piece and be able to generate revenue from that by billing for those services. So it's kind of a hard sell employing a program such as this, because a lot of administrators look at this as, well, maybe we're going to need to hire some extra staff, and this is going to cost a lot of extra money. How are we going to pay for these meetings and case reviews to happen? But really, when we're looking at other healthcare ailments, it's not a hard sell. A lot of times you see a diabetic care coordinator or navigator, or for cardiology or many other specialties that are helping patients navigate the healthcare continuum. And once again, the whole point of this program is to really keep patients at their best. The goal is, with patients that are using opioids or maybe receiving medications for opioid use disorder, that we make sure that they're parenting well and they're employed and working and they're functioning as they should be and to the highest level that they can be for satisfaction of life. So we had a controlled substance care team review form. And we had our quality department work closely with us to identify folks that were receiving greater than 90 morphine equivalents a day, because studies have shown that that's where patients that are at highest risk of having complications from opioid use. So we developed a review form that looked at multiple things, but I want to talk about the prescription drug monitoring program. And some of you may be familiar with that. And this is a program that is in several states across the nation. But what that is really a pharmacy log of any controlled substances that have been dispensed out of a pharmacy. So we really encourage nursing and providers to use this as a tool to ensure that there was safe controlled substance prescribing. For example, you could look on the PDMP and see, when did they receive their last controlled substance refill? Are they requesting early refills, or maybe they're not picking them up at all? It just kind of gives you a snapshot of what's going on with the big picture. Or in some cases, is the patient getting controlled substances from multiple clinics that we maybe weren't aware of? And not that that's something that's punishable, but just needs to be a conversation with the patient about their safety. Other things that this controlled substance review form looked at was previous workups. When were the last scans done with patients? Have they had recent labs? Just looking at the big picture. What previous treatments have been tried for pain? For example, if someone has back issues, have there been physical therapy? Has that been graduated? Did the patient give that an honest go and do therapy until the end? Did they maybe look at epidural steroid injections or other things that would be effective in back pain? And also mental health. A lot of times anxiety and depression can go hand in hand, and anxiety really can alter the patient's perception of their pain. So looking at if they've seen mental health and if they're getting the services that they need for that. Also co-prescribing. Are they maybe getting other opioid substances from somewhere else? Or are they receiving a benzodiazepine? Because benzodiazepines and opioids maybe don't go the best together. They cause risk for respiratory depression. So just looking at the big picture.
Yeah, I think one of the things to remember that was interesting out of these reviews was probably 20 to 30% of these patients either had a diagnosis that was not consistent with being on opioids, or we frankly could not figure out what they were on them for. We had many patients from the 80s that were started on opioids for anxiety. They certainly didn't need to be on opioids for that. A lot better medicine. So again, this review was a way of again, looking at how can we get these patients their best life and how can we be safe.
Yep. Sleep studies were also included in this review form because chronic opioid use can lead to central sleep apnea. Many of you are probably familiar with obstructive sleep apnea, but chronicity with opioid use can cause central sleep apnea, which Kirk can probably explain this, but
Yeah.
your brain doesn't trigger you to breathe when you're sleeping. It has nothing to do with, your typical sleep apnea patient that you think of maybe has the thicker neck and is a little bit overweight, which can pose some challenges. But it's a different type of sleep apnea and it can cause severe fatigue. So looking at that with patients too, to make sure that they're getting the rest that they need, because rest can also play into mental health and perception of pain.
And in my clinic, it's common. In the addiction clinic, I order sleep studies constantly. This is really kind of what then occurred is we would, after reviewing all of this, we would often sit down with the primary care provider. Some of the providers very receptive to some comments about patient care, some less so, I would say. But really what a lot of times we were looking at is this a patient that should be on opioids? Do they have the correct diagnosis? Do they have the correct follow-up? Are they getting the urine screens done? Do they have Narcan at home? And so there was just lots of things with recommendations that we would do. We were not looking to take everyone off opioids because some of these patients remained on opioids, but we would often, sometimes patients had there were better modalities to treat their pain, or often we were starting over with new scans and therapy and things to try and improve things. So really that was the purpose of that care team, was to give those recommendations.
And in meeting with patients to sign their controlled substance care plans, we oftentimes asked about function and how they were doing. And a lot of patients would say, well, I'm taking my opioids, but my pain is still at a 7 out of 10. And you'd ask, like, what are you doing during the day? Are you able to function as normal? And it was astounding to see as patients were being treated in different ways with the whole person approach, their function improved even when the opioids were decreased. So it was absolutely amazing to watch.
I think we always got to remember that there are going to be people who get opioids prescribed by a physician, and it will lead to a use disorder. It's amazing in my clinic when I see only addiction patients, how often I see patients who have had, some physical trauma, accidents, surgeries, dental procedures, or some type of other issue where they end up on opioids that never get discontinued. And so we as a system sometimes develop these patients and often they have a pretty rough time going through our system before they end up to me. And so just keep that in mind, is that whenever we start the opioids, especially with some of these more acute things, we have to have a plan, an exit plan. I think that's really a key.
So patients that are going to be at higher risk of developing an opioid use disorder are young, male, history of previous incarcerations, folks that smoke cigarettes, previous history of a substance use disorder. Childhood trauma plays a very large role in brain development and potential addiction. Earlier onset of substance use, family history, socioeconomic status, and racial groups that are affected with inequity are all going to be at a higher risk.
Yeah, and of course, as we went through the program, I mean, I think we all understand that there's things that are going to pop up that are going to make us wonder if we need to do a little bit more investigating, have a different conversation with the patient. You know, it's really whether they're overusing medications. Sometimes we'll find that they'll have their husband's medicines in their urines. They might be going to multiple prescribers, and of course, then we see the hoarders. And I can tell you, I've many times seen people who have 2 and 3 years of Xanax piled up just in case somebody stops their medications. And so there are things that make you want to just have that different conversation with the patient about, you know, about their use and whether or not they're concerned about their use.
And once again, the PDMP, the prescription drug monitoring program, is going to be an excellent way to sort of keep tabs on this and see the big picture with your patient. So predictors of or clues to opioid use disorder, you know, someone who's previously had a history of another substance use disorder, pay a little extra attention to them, as we know that they've had issues before and could maybe use a little more help. Someone that's had legal issues in the past, like DUIs or child protection services have been involved. Also, watch and screen for human trafficking. Folks that are engaging in that and fall victim to that generally have multiple sexually transmitted infections. So that may open you up to a more honest, open conversation with that patient if you have the opportunity. Chronic pain, as we know, that's a huge one that can potentially lead to an opioid use disorder just because of the chronicity of use in opioids. And then high risk occupations, a lot of times you'll see folks that have had physically straining jobs, such as construction workers or tree trimmers, which is a common profession in northern Minnesota where we're located. They can fall victim to an opioid use disorder just because of the wear and tear on their body and being uncomfortable and having strain. But also thinking about folks that have easy access to medications, like anesthesia providers
And nurses. Yeah, and nurses. I think that, you know, one of the things that when we, you know, being in a small town, I would often see patients that were in the paper for a DUI, and often that I would just keep that in the back of my mind for when I would see them, just to talk to them about other potential use. I think other things we should think about when we're looking for clues, or we're looking at who we need to be more attentive with. Family history is a huge issue. And again, you know, I see patients who are opioid patients who have 3 generations of opioid use disorder. And so it's a very common thing, and especially, and with alcohol as well. So it's not uncommon to have lots of people in one family with 50% genetics that have the same issue, or maybe similar issues. It's interesting to me because a lot of times if I see a patient who has a stimulant use disorder, everybody in their family has a stimulant use disorder. But it can cross, sometimes it'll cross lines. There's also, you know, different things when we think about when we're seeing a patient that might trigger us to have further conversations. Sometimes you look at patients and they're just, you know, low self-esteem. They just don't seem quite right. They lack that self-respect and self-concept. So the patient's really obviously struggling. And I think that then when we have them in the clinic, we really need to have the conversations with them to make sure that there's not something going on that we can help them with.
So like Kurt said, further morbidity, I'm having some challenges today.
Again,
On interpersonal relationships, you know, maybe their family isn't as close to them. Their friends are kind of, you know, falling away. Social relationships are going to the wayside. And there's also challenges with finances and legal issues and employment performance. Maybe school and grades are falling. Those are also things to pay attention to.
One of the things that I often talk about, especially with like students and residents, is don't always think that when somebody fell at home that they just tripped. We always have to think about the substances that they use, and falls are a huge problem in people who use substances. I mean, 27% of older adults, and I use older adults as 65 and above, the closer I get to it. So we're gonna say these are older people, 65 and above, but you know, more than a quarter fell. And so we should often be thinking about why they fell, right? Is it a medication? And we should be trying to address kind of these modifiable risks. And medications are a very common cause of that. And I think that when we're concerned about patients who are on opioids and we're having conversations with them, we have to think about their risk of hip fracture and other things. And there's been great studies that have shown that it does not take an enormous dose of opioids to put people at risk of significant injury. And remember, if you fall and break your hip, the 1 year survival is sometimes right around 40 to 50%. I think most people would be surprised to find that such a small dose, if you were taking oxycodone 10 milligrams 3 times a day, it increases your risk of fall by 50%. And so again, when people are falling, we want to have the conversations if they're on opioids and look at ways to adjust and to make them safe. And so it's not just, how you doing? I'm good. How's your pain? It's all these other things.
So sleep apnea, like we talked a little bit about earlier, is definitely a challenge in patients and something to screen for, because patients that have been chronically receiving opioids may report that they're just so fatigued, and this is causing other challenges in their life. So it's something to definitely think about, is ordering a sleep study to see if that's maybe what's going on. Or if the patient has a strong family history of obstructive sleep apnea. And if they're obese, they should probably be evaluated for a sleep study prior to prescribing opioids, just so we don't cause increased respiratory challenges.
Yeah. I actually had a lady who was 75 who'd been on chronic opioids for 25 years, went to the ER for anxiety, and they gave her 5 Ativan. She went home and took an Ativan and stopped breathing, got intubated by the paramedics and taken to the ER. And as it turned out, she had sleep apnea. And when they just added 1 Ativan to her opioids, she stopped breathing when she laid down to take a nap. And so again, don't underestimate the effect that even just a small change can make.
And then testosterone depletion is also something to think about or watch for in patients that are chronically prescribed opioids. It can cause hypogonadism, which is linked to all-cause mortality, and treatment with testosterone products will reverse the effect and decrease all-cause mortality. But I guess that was something that I never realized prior to working in addiction medicine, that was something that was a result of chronic opioid use.
Yeah, I probably order testosterone twice a week on patients with long-term opioids. Really pretty amazing how often that happens. And I think also we need to have conversations with patients, because again, this is always about safety. And one of the most interesting things is how little, when we have people on chronic opioids, we talk about their alcohol use specifically. I mean, obviously you're going to know if they're on a benzodiazepine, but older adults are at much higher risk of issues when they use alcohol with their opioids. And so it's really a part of our visit. Again, I think a lot of my partners over the years thought that a chronic pain patient on opioids was a 5-minute visit. And it should not be. It should be a 20-minute visit where we really look at all of the things that can put them at risk.
So the king of all kings, what is the probably most fatal adverse outcome that there is? And that is development of an opioid use disorder, which folks are at high risk of when receiving chronic opioids. So that's why it's so important to put some sort of standardized process of prescribing in place within your facilities.
Yeah, and monitoring.
So Dr. Koob, his definition of addiction, and really honing in on addiction, is a chronic relapsing syndrome. So it's really no different than a patient that has cancer or a patient that has diabetes, chronic relapsing disease.
Yeah, an important part of this is it's this compulsive disorder involving negative reinforcement. And I really want to emphasize this, because often we talk about why patients don't just stop. We've both seen people come from the ER where the ER doctor's written, stop using opioids, but the reality is, if they're sick, they're not using opioids to feel great. They're or to feel high. They're using opioids to not feel sick, which is a negative reinforcement.
So this is one of my favorite slides to use when I give presentations. And I guess I was never a judgy jerk, but prior to working in addiction medicine and with controlled substances, I never really understood why patients couldn't just stop. You know, they're losing their house, they're losing their children, they lost their job, you know, things are happening that they don't want to happen. But like Kurt said, they're not using to get high or any type of euphoria anymore. They're simply using so they don't experience these absolutely horrible withdrawal symptoms. And patients have described to me that opioid withdrawal feels like the worst flu you can imagine times a million. And like their bones are on fire or crumbling from underneath them when they're trying to walk. So, you know, you look at all of these things, severe dehydration is happening. There's a lot of really painful things that happen with opioid withdrawal. So it keeps patients in an active cycle of needing to take opioids so they don't experience these things. And also, other things to think about are increased suicide risk. I've had so many patients say to me, I'd rather be dead than experience withdrawal again. So just thinking about the risk of self-harm that goes along with this too.
Yeah, and I think it's important to understand that to actually qualify for an opioid use disorder, we've got 10 things that can each be worth a point, that can, where you are trying to recognize somebody with an opioid use disorder in your clinic, in your ER. And I'll tell you that for the most part, when we're prescribing the opioids, if you look at the end here where it talks about tolerance and withdrawal, those do not count. And so if I see a patient, which I did yesterday, who was being prescribed opioids, she had tolerance, she was in withdrawal, but she was being prescribed opioids and had been, her meds had been stopped by her doctor. So I can't use those as criteria. In most patients, the one thing that's going to be most predictive is if they're going somewhere to buy extra pills or taking extra pills from someone else. If they're doing that, they will have 3 or 4 more of these points to give them that 4 to 5 points as a moderate opioid use disorder. So just understand, to me as an addiction doctor, that's one of the first questions I ask, because that gets me right where I want to be. And it's really important for us to be able to recognize it. You know, when patients walk into the ER and they're having some issue, it's worth our while to understand what it looks like if they're using or if they're in withdrawal, and the big difference between that.
Yep, definitely. If you're prescribing higher risk substances, and opioids are those, you're understanding what withdrawal and being under the influence of the medications looks like. So someone under the influence of opioids may have slurred speech, very pinpoint pupils, present with gastroenteritis into the emergency room. And, you know, this is very anxiety producing for them, the thought of maybe not receiving another fill of their medication, because like we talked about, withdrawal is just awful. They may appear sedated, they may have lost some weight, had potential injection sites, or maybe sniffing. That can be a side of withdrawal. And then on the flip side, if they are in advanced acute withdrawal phase, their pupils are going to be very dilated. You may see some sweating, some sniffing, things like that. And they're very uncomfortable, nausea, vomiting, diarrhea. Their joints are very painful.
Yeah, a lot of times when I get a call from the ER, they'll say, I have the sickest person I've ever seen, and they're rolling around on the floor.
Hallucinating.
Yeah, and then I know that they're really in withdrawal. And I think, again, just to reiterate the fact that this is a chronic relapsing disease. We expect that people are going to have issues. This is like diabetes. This is like cancer. And we need to shift the way that we have these conversations with patients more to how we can help, or what can we do to kind of get us out of this cycle that we're in at the time.
Yeah, I mean, if someone's in remission from cancer and the cancer comes back, you'd never say to that person, why did you do that? What'd you do that for? And I feel like as a society, there's a lot of stigma surrounding opioid use and addiction, and that's how we handle it. But once you switch your mindset to why did you do that, to how can we help, patients really open up and they're willing to talk to you and have the hard conversations so you can actually treat the problem.
Yeah, and so it's important, you know, again, I think we've got to change how we think about this. We're not trying to catch anybody. We're not the police. We've got to do our best not to stigmatize, you know, opioid use that's prescribed, opioid misuse. We're just there to help.
And we really need to address this as a nation a little bit differently, because as many initiatives that do exist, we're really not making a dent in the
No.
overdose deaths that are occurring. So that's where it's really starting to look at controlled substance use, controlled substance misuse, just as any other disease process that needs to be treated, just so we can attempt to have some sort of intervention and save some lives. So population health really fits into this, because communities that do have overprescribing occurring within their healthcare facilities are going to see increased emergency department visits, maybe infectious disease problems, because HIV and hepatitis, sexually transmitted diseases can go along with high risk behavior once someone has developed an opioid use disorder. You'll see an increase in incarcerations. And if you're, stay up to date on looking at who's booked into the jail, you may see a lot of drug charges going along with that. And then overdoses. That's going to be a huge indicator that there's an issue in your community and something needs to be done to help. So population health, medication for opioid use disorder. So you can give medications to treat opioid use disorder, and we won't get into that in a lot of detail because that's another hour-long discussion. But in our local jail where we developed this program, patients that were given medications to treat their opioid use disorder served far less days in the local jail than before they were in an opioid use disorder program. So you'll see on average, 3 years prior to being in a treatment program, spent 56.7 days in our local jail. And after they were on medications to treat opioid use disorder, spent as little as 4.7. And really that number isn't accurate because some of them were serving on old charges that they had to go back to jail to do their time, but they were successful in a treatment program. So value-based care, why is a program such as this revenue generating? So rather than referring your patients out, the patients that you're already seeing in your primary care practice, you can offer treatment options to them in your own facility. You don't have to be an addiction doctor to be able to offer medications to treat opioid use disorder. And once you have your patients and build a rapport with them and build a relationship, you want to keep those patients for the long haul. So, patients that have an opioid use disorder, they're going to have babies. So it's important for your OB department to be able to care for folks that are taking opioids or medications for opioid use disorder. They also have surgery. So it's important to know how to deal with opioids and manage pain, both pre-op, intra-op, and post-op. And they're also going to have accidents because life happens. So they're going to present to your emergency department. Just knowing and being educated on opioids, the effects, and potential for opioid use disorder. And then, like I mentioned a little bit earlier, patient-centered medical home. I would encourage all to check that out and see if there's any potential for that in your facility, so you're able to bill for some of the care coordination services that you weren't before. And it's a really strong argument as to revenue generation, and it's the right thing to do for the patient because they're receiving those additional care coordination services.
So we're going to talk a little bit about our program. We're going to have to go through this quickly as our time is running a little bit short, but really just to give you an idea of what we did in 2015, we started this controlled substance care team. And it's pretty interesting what happened. We looked at 3 of the 4 pharmacies in our area, and we had 100,000 opioid pills going out a month, and we had a population of 30,000. I think the number was probably a lot closer to 120,000 if we'd added the 4th pharmacy, but it was really almost 4 pills per person in our entire county. And really our initial focus was we just have to have fewer opioids coming out of our clinics and hospitals. There's no sense in, no sense in doing anything until you've just got less of them coming out. You turn the water off before you start to mop. And it was really amazing what happened in our community. In 2014, the #1 reason people came to our small town ER was because they ran out of their opioids or they had pain. And really within 12 months, that went to number 20th. And so we really with care plans, with close monitoring of patients, with really addressing their problems, we really made a difference in the patients that came to our ER and why. And we actually had 684 patients that had one of their controlled substances discontinued. And it ended up being, we were shooting for a million pills, but it ended up being almost 800,000 pills over a couple of years. And so you can really make a difference if you closely monitor patients, if you watch for safety issues in your patients, and you really closely look at why patients are taking these. I think that's really an important thing. And so this just shows on the bottom there, it talks a little bit about some of the supports and referrals. We sent a lot of people for physical therapy, a lot of people to social services, all different types of things to kind of help them. And we weren't just covering it up with pills, we were sending them to places that could also help them. And then this happened. We actually got funding from the state, and we actually took this to 12, and then eventually I think 13 different communities, where we basically started this program in all of these communities all over Minnesota. And they got grant funding to actually hire what I feel like is the most important thing, which is that nurse care coordinator.
So duplicating the program, what do communities need to do? First off, just monitor prescribing of substances that we know are high risk. What are you doing to standardize opioid prescribing? And then we took it to the next level and assembled a county task force. And really, this was so much fun because you don't realize how siloed you are as a healthcare organization, because there's so many people that have a touch point in the lives of people in the community. And it does take a whole community to address an opioid issue. So we had law enforcement, local treatment facilities, local pharmacies,
Nursing homes.
Yep, long-term care facilities.
Oh,
Yep.
sorry.
Yep. And several other folks that had a touch point in prescribing practices and long-term outcomes. And we had the controlled substance care team. And we really encouraged at least one buprenorphine waivered position to be present in each of those communities. And buprenorphine is a medication that we like to use because of its safety profile to treat opioid use disorder.
And really, we already went over that slide. Really, the one thing to really think about is, as long as there's opioids around, we're going to have to be careful. There's going to be issues and problems. And really, the important thing, I think, for any program that you institute is really being proactive. As you can see, this mouse is wearing a helmet. That'd be, in my mind, that helmet is Narcan. And we can have all the Narcan around everywhere in every space, but that mouse is still going to go for that cheese, and sometimes the Narcan's going to work and sometimes not. And so really, the cheese being the opioids, we really need as a society to really decrease the diversion of that, the misuse of that. And I think physicians and anybody who's a prescriber really has to take this seriously, and the monitoring of these patients.
So things that we talked about that are tools for your toolbox. We talked about internal report running for morphine equivalents. And a great place to start is having your quality department run reports on patients that are getting greater than 90 morphine equivalents a day, because studies have shown that places them at an increased risk level of adverse outcomes from opioids. Also, you want to say something?
No.
Okay.
I got nothing.
And then we talked about the prescription drug monitoring program, and that is an excellent tool. Have that printed out, have your doc pull that up, have nursing pull that up prior to a visit of a patient who's chronically receiving opioids, just to make sure that there aren't fills that are occurring from other providers, that they're not requesting early refills, and that they're on track. And as we've said so many times, this is not intended to be a punitive tool, but just to ensure that the patient is safe and safe prescribing practices are occurring. Also, there's these fancy little buggers called CMS report cards, and they look at Medicaid patients and Medicaid patients that are being prescribed controlled substances. So in this, they found that there were several providers that were overprescribing in comparison to their peers. So it really was a nice way for healthcare organizations to develop and assist their overprescribers in quality improvement plans. And that was also the project that Kurt and I helped with in the state of Minnesota, was doing quality assurance calls with overprescribing practitioners. And it was amazing, just really, the calls were great because it's just looking outside the box and talking about many of the interventions that we discussed during this presentation. Pretty simple and pretty practical. Also, implementing care planning and urine drug screening, once again, not to catch or kick anybody out, but just to open up conversation with your patient and make sure that safe prescribing and correct pain management is happening. Narcan, once again, utilize those reports from your quality department, and anyone receiving greater than 90 morphine equivalents or 50 if also using a benzo with an opioid substance, just automatically tee up Narcan in their chart so they have that ready to rock and roll when they pick up their opioids from the pharmacy. You can save a life. And I always talk to patients about, even if this isn't for you, it's a good thing for you to have. We were giving a presentation in Atlanta, 2 years ago, and I just happened to walk up on somebody that was having an opioid overdose on the way to the summit. So you never know when you're going to need it. And like we've said, and like the Viking Stadium showed at the beginning of this presentation, opioid overdoses aren't going anywhere too quickly. So you'll never know when you're going to need Narcan, but it's a nice thing to have. Taper planning is another tool to have in your toolkit. Like we recommend, don't ever cut somebody off of their opioids cold turkey. That is not proper patient care, because as we talked about, patients, when taken off of their opioids, could experience all of those horrible acute withdrawal symptoms. And that is just inhumane healthcare to make somebody experience something like that. And then patient-centered medical home is another tool for revenue generation within your facility, because if you're looking at hiring care coordinators, there's billable services that come along with that.
We'll talk just for a moment. Again, we're running a little short of time. We run a weekly echo on addiction, one of the biggest ones around. We have speakers from really all over the country. And so we have speakers every Wednesday from noon till 12:15 to 1:15, and there'll be an email at the end if you would like to get some of the information about that from Erin. She can send that to you. But it's a great way for us to treat or to help educate rural Minnesota and really beyond. So we've been doing that for a long time. The key really is we're teaching other people to do what we do. We can't see all the patients with addiction in Minnesota, and so it's really our team teaching another team. And this is something that Erin and I do every week, and probably the favorite parts of our job. This actually shows where the people are that listen to our echo. We average somewhere between about 50 and 80 people per week, and it's a wonderful group of people who take care of patients all over Minnesota, and even in North Dakota and Alaska. We have different people that listen. These are the great pictures of all the fun we've had. So
our echo team.
Yeah.
So what is our role at Stratus Health? We have a really nice website that has a bunch of great resources on opioid prescribing, addiction medicine. We have a manual on how we really rolled out this program in other sites and mentored them to follow these interventions with opioid stewardship. So there's a lot of great resources. Check it out. You can always reach out to us. My email is at the end of the presentation if you have any further questions on resources.
Some of the other things we do, we actually do boot camps. We have one coming up where we really teach all of this to communities, which is super fun. Again, we talked about the echo, but we have lots of different protocols for all parts of the hospital, the jails, the emergency departments. Really something that we've really kind of perfected over the years. They do get changed sometimes, but they're honestly, it's just something that we've tried to improve every year. And I think that might be it.
I can't advance. Okay. So I will stop sharing and open it up to questions.
So I want to start by saying thank you so much for this presentation. Absolutely amazing and so well done. And just brought such a compassion to a topic that is usually filled with so much stigma. So thank you so much. So I'm going to open it up for questions. You can just unmute and ask the questions or put them in the chat box. We do have one in the chat box so far. Is urine screening a requirement in Minnesota or per insurance payer?
It should be. A lot of insurance payers like to see a urine if someone's receiving a controlled substance done every 6 months.
Yeah, the state guideline is different than the CDC guideline. The state guideline is once a year. The CDC guideline was 2, so a little bit different. But those are only guidelines. The insurance companies kind of rule the world, as we all know.
I have another question.
Hi.
Hi, good afternoon, everyone, and thank you so much. This was really, really good, really helpful. I was taking screenshots and sharing it with my team of community health workers, especially the picture of, why sometimes people are using it just to avoid the withdrawal. That particularly was very powerful for me personally and with the team based on their reactions. My question for you guys is, what, if any, role do you see community health workers playing in this model?
Knowing your resources. I think that is the biggest thing, is just, I think that's my biggest surprise in going into communities to help mentor them, is just how siloed everyone is. And we were no different where we were, and just understanding who's doing what and resources that are available. Talk to your local healthcare organization and your local correctional facility. Are they offering services, or do they have a stewardship program in place? Encourage them to if they don't.
Yeah, and I think just knowing where a good, addiction, either treatment or in our case, clinic is, where they can come get care that's non-stigmatizing, where they can actually get the care they need, and people are going to treat them the way they should be treated, right? I mean, I think that's the most important part.
Yeah. And then Heather Miller. Whoops, sorry.
Go ahead. Go ahead. Yeah.
Heather Miller put in the chat, do you utilize any population health tools to track your patients and pinpoint those at highest risk? I guess population health, it kind of falls under what we did in our clinic and working with our quality improvement department in identifying those receiving above 90 morphine equivalents of an opioid a day. That was how we identified our most at-risk population. And we started with opioid. And after a while of getting folks that were receiving opioids care planned, we went on to stimulants and benzodiazepines and other substances that also can have adverse effects if not monitored with prescribing.
I think one of the biggest things, and I'm actually giving a talk that I've given a number of times on opioids in the older adult, and is really educating the provider. Because often when providers are seeing these people, they don't consider the things that put people at higher risk. These are things that are often hard to track. Sure, you can do it with particular diagnosis, but it's some of the things we mentioned, especially like patients with COPD, patients, that are at the highest risk with their other health problems. We need to have the providers be able to recognize when they need to make safety the priority, which is always.
All right. Well, Dr. Devine and Aaron, thank you both so much. We might have to plan a part 2 somewhere down the road. This has been an amazing presentation. And for everybody else, just as a reminder, we'll be sending out the link for the survey if you'd like to fill that out to get credits. And then also this has been recorded, of course, and so we will be sharing that on our website and emailing everybody who attended. And so please share this widely with others so that folks can look at the recording. But again, thank you again, Dr. Devine and Aaron. Appreciate it so much. And for everybody else, please have a wonderful rest of your day. And thank you for joining us. Bye, everybody.
Thank you.
Bye.